Okay, welcome back everyone to the Mid-Atlantic Virtual Summit. It is now time for our final session of day one. As a reminder, we return here tomorrow, Tuesday, for day two of our program, which will be beginning at 9:30 a.m. Eastern Time for a fireside chat with Penn Medicine. And immediately following that fireside chat will be a panel discussion on making sense of the digital solutions available to your organization. For those of you who are just now logging in for the first time, if you would like to submit a question during this session, please utilize the chat function within the Zoom platform. Also, all of the sessions from today are being recorded and will be made available to view on demand, and those should be up by this evening. Okay, now it is time to kick off our final session, or to begin our final session of day one, which is telehealth growth in 2021 and beyond. This final session is being moderated by our managing editor, Rajiv Leventhal, and I would love to now bring Rajiv Leventhal, I can't say on stage, but on the virtual stage to kick off this fireside chat. Rajiv, take it away.
Thanks, Matt. Really happy to be here and excited to close a program with a great conversation. Just one programming note, a little bit, probably 10 or 15 minutes before the top of the hour, we will be cutting the cameras, but have no fear, we will still be presenting and conversating. We just won't be on video, we'll just be on audio. So no need to do anything. Just wanted to let you know that if our faces do disappear for whatever reason, we will still be continuing the conversation audio only. So as Matt said, we're going to be talking about telehealth and remote patient monitoring. Obviously, there's so much that has gone on in this space over the last year and a half. But, really, organizations like Geisinger, who we're going to be talking to now, have been innovating here for a while. Geisinger has been doing work in the hospital at home space and all of the technology that is involved with that for a decade or so. And with that, I'd love to introduce the leader here who I'm going to be conversating with over the next 30 minutes. That's Joanne Chandra. She's the Vice President of Care Coordination and Integration at the Pennsylvania-based Geisinger. Joanne, thanks so much for joining us. Can you briefly take 30 or 60 seconds and talk a little bit about real high-level overview of your role and your work specifically in the remote monitoring hospital at home?
Yeah, absolutely, and thank you for having me today. I'm a nurse by background, and I'm very proud of that, so I always have to call that out. Currently, I oversee outpatient case management for the health plan as well as Geisinger Health overall. Our outpatient care management, case management department consists of nurses, RNs, LPNs, community health assistants, respiratory therapists. We also have a special needs unit that we actually brought up and running greater than 5 years ago when we went live with Medicaid. So they're people that do high risk management of peds, OB. We also have behavioral health and several other areas that I'm directly involved with Geisinger. My journey on telemonitoring started in 2009. So back in 2009, we had a homegrown heart failure system where the patient called on the phone and they pushed some numbers and they left their weights. And then we actually had someone call back just to verify the weight and do some follow-up. So at that time, we were growing and our heart failure population was growing as our gold product, started to grow at the health plan. So what we did is we partnered with advanced monitoring caregiving systems out of New York, and we started using scales. So early on, we started using scales, we started using interactive voice response. And over the years, we've just added and added, to our catalog or our portfolio of monitoring that we use for our patients.
Yeah, that's great context, Joanne, and really want to dive into some of the specifics. So you mentioned that that's where this journey started 12 years ago or so. Can you talk about the decision to maybe move on to other conditions and issues that you would be treating in the home, and why those specific ones were chosen?
Sure. A big part of it is having the staff to do the work. So I think we all probably appreciate the more contact that we have with a patient. It helps us really grow that relationship. It builds trust, right? And it gives us the ability to know if patients are starting to get in trouble. So there were some of the issues we had in front of us, how we're going to continue this work, touch more people. And then we had patients outside of telemonitoring that we had to manage too. So one of the things was really to provide more data to the team and the ability to intervene earlier and the ability to have patients really have exacerbation plans in place. So what we did was first starting with the scales, and we saw how we did, right? And then we started to really look more at, can we do anything different around preventing readmissions? Does it always have to be a person doing the work? And for most of you out there, you probably be challenged with the same thing, or are today is, we think as nurses and as other healthcare providers that we can never be replaced by a tool, whether it's a monitor, whether it's an automated phone call. And what we found out was that wasn't true. And as we moved through, up to 2014, we started doing some research with our partner in telemonitoring. And what we found was we were decreasing readmissions and we were decreasing admissions for heart failure. One thing I will tell you though is we have never done it standalone, meaning that we always have it connected to a clinical arm. So there's always that clinical arm that gets the alert, but they're the ones that really make that call and do the deeper dive and find out what the next step should be.
Yeah, no, that makes sense. And I think that combination is a winning combination. You mentioned the staffing that's required to support this, right? That's obviously a huge issue. Can you talk about how Geisinger's technology and IT foundation has expanded over the years? Technology is obviously a big piece of this. What were some of those opportunities like as you look to continue to expand that technology foundation to support this work?
Sure. I mean, one of the things that we did was once we kind of looked at heart failure, we said, what's next on the horizon for us, right? So our nephrology patients, what's the benefit of having daily blood pressure monitoring? Most recently in the last year, we have actually teamed up with our OB department. So for gestational diabetes. So today we have moms to be that test their blood sugar every day, and we're able to make adjustments and monitoring based on those readings. I hate to bring up the pandemic, guys, but it's reality, right? We always don't want to go back to COVID, but COVID really started to change the way I think as an organization, we even more appreciate what telemonitoring and telehealth can provide to the organization as well as our patients and our providers. So at the onset, back in January of 2020, we were just starting to pilot a 24-hour monitoring system. And at that time, we said, do we really need this? Is this something we're ever going to use, and will patients really use it? This monitoring system has the ability to tell us patient movement, their pulse ox, their respirations, their surface temperature, as well as, of course, their pulse, right? So here we are back in January thinking, who are the patients we're going to put it on? Well, as time came, right, here came COVID. And we had calls from our leaders within our hospital system saying, we need help, right? We need to monitor these people closer at home. And are there patients we could safely get out of the ER and get them home? Because we need to start to cancer hospitals. And all of you have that reality. So back then we started using our 24-hour monitoring system. And I have to tell you, we've had a lot of great wins in it. Patients that routinely would have maybe dropped a pulse oximeter or got, their reading or got short of breath would have been in the ER. But here we are now able to see what's going on 24 hours. And it was really about trending and really looking at how the patient's been behaving over a period of time and not responding to one dip or one change. So patients now that would have went to the hospital, we were starting home oxygen, we were increasing oxygen. So we were really getting ahead of the game. So when I look at that technology, that's been a great thing, the addition of this 24-hour system. But I will tell you, COVID's kind of dying down a little bit. Now we're starting to learn, how do we use this for chronic care? So what's the place for this in heart failure? What's the place in COPD? How do we use movement to help our patients, recover or stay at home? So lots of work being done in that area. And, I could keep talking if you'd like me to talk a little bit how we've used our Surface Pros and our InTouch. Would you like me just to go right to that?
Yeah, absolutely. I want
Okay.
to on the COVID situation one more time, but yeah, please, let's
okay. So we'll get started. We have a Geisinger at home model of care. Yeah. And this model of care is not home health. It's not house calls. It's not just a doc going into visits. And many organizations have been starting this over the last couple of years. So this is a team that is led by a primary care provider with nurse practitioners and PAs, nurses, and everyone you could think is part of the care team that provide care to a distinct patient population within their home. So we're doing IVs, we're doing nebulizers, anything you could think of, we're doing within the home that could be done safely. When we started this model, the big question was back to how do you touch enough people? And now you're driving all over the place, right? So is there an opportunity to use some type of technology that the provider does not have to be physically in the home? So probably 2 years ago now, we started to look at InTouch. And InTouch now, I think, is owned by Teladoc, right? There's been some transition since we started. So InTouch, as many of you may know, is a device that go into the home, and it has the ability to do a video visit. And it also has the ability for the provider to listen to lungs, look in the ears, look in the nose, or look at, does the patient have swelling? Is there a rash, right? So we can do the video part. So what we've done is we've taken that device and we've used that on our most complex patients to do a telehealth visit. So the telehealth visit isn't just a phone call and really going through a series of questions and relying on that patient to give you the right information. It's really like an office appointment. So we took our community health assistants and we actually, every day they go out and they see patients within their home and they set up an office visit, right? The meds are there, they're getting the office visit set up. And our providers from their office setting will call into the visit and actually do a visit. But now they have a lot of information to make a lot more decisions. Again, it's a complex population. It's not the population we're just talking about having a cold. It's the population with a cold, with COPD, with kidney disease, that really readings are going to make a difference. So as we moved into COVID, as you can imagine, this was huge. So right through COVID, our teams were still out there in the field, but we had the ability for our providers to touch more patients due to having these devices and having the community health assistants out there. So this has been really a lifesaver for us. And it, you know, the patients like it, and the patients, they still really, those sick patients want to know that you know their blood pressure. You know, they struggle sometimes with just that conversation. So it's been very helpful. But keep in mind, we still have patients that we're doing traditional telehealth visits on, and they work out very well too.
Yeah, of course. And, you know, that evolution is quite fascinating. So back to the COVID monitoring, it seemed like these were not necessarily patients who were mildly symptomatic, that the actual monitoring took place with patients who did have breathing and lung issues, and otherwise, if this program was in place, would definitely have been admitted to the hospital. Is that right?
Absolutely. So, and there were some young patients, guys, without any comorbids. So maybe we gave John a pulse ox, just a routine pulse ox. But as we followed up with him, our case managers proactively called, he's 90, he's 89, he's starting to have issues and challenges. We convert him to the 24-hour monitor. So really, it gave us a backup. And then if we were going to do any kind of treatments within the home, it gave us a really better way to monitor. Keeping in mind, this is not EICU. We did not watch these monitors at 1 a.m. and 2 a.m. We stayed away from that. We actually looked at more trending, and we really felt if a patient needed that level of monitoring and that level of intervention, the home wasn't the right place for them, you know, in this situation.
Right. Also, from the patient perspective, you know, there are probably lots of different technology issues or challenges that you've had to kind of navigate around over the last, you know, several years. You know, I remember speaking to a leader in the space a couple months ago who was saying that it was a technology company who makes RPM equipment, and they were saying the biggest technology challenge is actually simple internet and broadband issues where, you know, 25 to 50% sometimes of patients in a specific area might not even have, you know, the necessary internet. And this is not just in rural America, but it actually could be in San Francisco and New York City. You know, being obviously in Pennsylvania, there are some rural areas there. How big of a challenge is that, and what other issues from a patient infrastructure standpoint would you put right up there with that?
Yeah, so when you said that, the first thing I thought of is that patients The first question was, when we look at a patient that was in the ER, even today, if it's not even COVID, right? Or patients at home, do they have the technology to support it? And do they have the internet to support it? So if there's a question in mind that that patient cannot reliably transmit, it's off, we're not going to do it, right? That patient needs to go to the ER, or that patient needs to be seen in the hospital. So I think that's the first thing, being very mindful of that. The second thing is just exactly what you said. There is definitely a challenge in certain areas. And over the years, I think we've done a good job, our team, to really identify those areas. And we know those areas, and we know where they're at, and we know the challenges. So some of those challenges, current state, I can't do anything about. Neither can the patient, neither can our team, right? So we do our best within those situations to make sure the patient's connected the best way they can be. And I have to tell you, you mentioned the provider of the technology or the telemonitoring equipment. They've always been very helpful, to find different ways. Years ago we used modems, now we could use things on cell phones, and they've really come to the table with different ways for patients to connect. The other challenges from a patient perspective, I think, is just understanding and being the right patient. We fail in telemonitoring when we don't do a good job telling the patient about it. And meaning that, this is something we do every day, this is something new. And if that patient is hesitant about it, it's not the right patient. Because what we find out is then we have challenges. They don't monitor. If it's not 24-hour, they're not weighing themselves, right? So when that happens, your team is going to spend a lot of time chasing themselves to try to get the patient to do it. And this patient may never do it. You just have to accept it. And what's the next best thing for that patient? Maybe the next best thing for that patient is not a Bluetooth scale, a home scale, and you teach them or give them an algorithm. If your weight's this, call. Get your patient to agree to that, right? So it has to be the right fit.
Yeah, that's right. You mentioned the next frontier kind of being around chronic care management and everything that goes into that. Has your team, has Geisinger thought about, what it will take to be successful in being able to manage complex populations through, remote monitoring?
Yeah, I think we've done a lot of that, even since 2009, with decreasing heart failure readmissions and, decreasing readmissions generally. But as we look at this population, their needs are growing, right? And, how do you replace that human touch? I think where we see this going is really the ability to put on the right patient at the right time and have it connected to the right intervention. So the patient has to feel really secure that if there's a change in that monitoring, that they can see that someone's going to respond to them and have the right education. We're in the process of really revamping some of the work we do with the new platform, a new care management platform. And I do believe that's going to help us with a lot of these issues. But, I'm talking monitoring devices too. But what about texting, right? So what about that patient who would rather us push out a questionnaire, which is very common today, via an app or via something else? That's stuff we're really getting to play today. But I think it's really about the right population. And when I look at somebody that's very complex with heart failure and having a lot of exacerbations, that may not be the right person. They need that care manager, that case manager touch, a few times a week. But how do we use it for the right population? And I think we're learning that every day.
Yeah, and that will be, I'm sure, an iterative learning process and continuing learning process for sure. Thinking, and we've gotten a few questions about this, which is interesting. Thinking about the future of remote patient monitoring and telehealth, a lot of it will be tied to the payment structure, the reimbursement structure, right? Will doctors be as on board, with this, if some of the flexibilities and around the payment landscape that were in place during the public health emergency are removed? What can you say, what insights can you share around how payers will continue to support the telehealth visits for patients who want telemedicine for convenience versus maybe strict medical need, and some of the other barriers that Medicare has kind of put, Medicare, Medicaid kind of put in place? If they remove some of them, do you think that the growth here is a little bit tapped or not really?
So first, the first thought that comes to my mind is at a state level, right? So we have managed Medicaid, as many do, in the state of Pennsylvania. So we've already heard from the state and Medicaid that this is something they want to see as health plans that offer a managed Medicaid product that they have in place, right? That they have telehealth in place. So they are very, very supportive of it. As a health plan, we too are very supportive. It's not going away, right? But to your point, I think it's going to be about reimbursement and what that reimbursement is. So, our team that works, our analytic team, our people that do the contracting and stuff, they're working hard with the provider world to come up with, what is really the right rate that should be, reimbursed for this type of work. So I don't think it's going away, and I'm sure everybody on the call would say the same thing. We're just going to get deeper and deeper into it. Personally, I think it's for the right person, right? The right patient. Sometimes patients do just need that contact like you and I have right now to say it's okay. And even those chronic people, sometimes that is okay. But how do we really carve out the patients that need more than that need that face-to-face in the office? And what does that look like? Does every patient required to have 2 face-to-faces a year? And everything else could be, done remotely. That's stuff we're working through right now. And I can't tell you that I have the magic answer for that yet, because I think we're learning like everyone else. I mean, what I can tell you is patients have been very receptive to it, right? And most patients, once they figure it out, they're okay. They find it very vital, but they are still patients that want nothing to do with it, and they want to be in the office. And I think that's okay. I don't think we want to get rid of that face-to-face ever.
Yeah, and as you're kind of thinking about what will be the criteria that determine what patients are the right ones for this setting?
Right.
Question from the audience: what are the credentials the individual who needs to go to the home and work with the patient to be observed remotely? How are those credentials determined?
Okay. Yeah, that's a very good question. So what we've done is we took our community health assistants and we trained them. First, we trained them on the device itself, how to use it, and then we walked them through everything else on the device, right? Where does the stethoscope go? How do you use this video? How do you do different things? The other piece of it was what we're finding is as they go in, the providers are asking for more. Hey, can you push down on that leg? Let me see if there's any pitting edema. So what happens is the community health assistants, again, non-clinical, really either right out of high school or right out of college with some kind of a community background, are very hesitant. They're like, oh, I can't be, doing this. It's out of my scope, right? So what we do is we take them to a Sims lab. And that for us has been the most effective, taking them to a Sims lab, do a couple of trials and stuff, do some coaching. Then when we take them out for their first couple of visits, we send usually one of our educators who's an RN who's very, knows how to do this stuff. And they actually check the box that they're doing everything. And then we actually are going to probably do yearly evaluations on them. But starting with the Sims lab was very effective because we didn't want them going to homes and really like not knowing. And it still happens. Sometimes the provider will say, can you press down on the patient's belly? So I think there's a point where you got to say stop, right? And there's a point where, we probably need a provider. We actually have a robust paramedic program. So paramedics that we can get out to the home to do assessments and not necessarily transport. So that's very helpful too. So if the provider's on the phone, they're in the home and there's something that's out of the ordinary, we can either send the paramedic or we actually have acute nurses out in the field that can respond to that.
Right. You mentioned at the top the readmissions, the lower rates, and I think there's been other research in academic journals and other places that have kind of backed that up as well. And there's also been research. I think there's one big study that found the hospital and home patients, the care that was being delivered was like 40% less costly than if they were to be in the hospital admitted. Are those the two kind of the big metrics that you look at? And as you go for readmissions and costs, and as you go forward, what are some of the other ways that Geisinger will measure progress and kind of ensure and make sure that they're hitting certain benchmarks?
Yeah, I think a big thing is we just really started digging into his days in the community. So days the patient's out of the hospital, right? Which is something that we've really never looked at. So traditionally, readmissions, acute admissions, ER, they're like your top three to look at, or observations too. I pull out observation too. But looking at some of these chronic complex people, how long are they in the community? And because we know that if they're in their community, their quality of life should be better, right? And their outcomes hopefully are what they need to be. So that's, some of the stuff that we look at, but, also looking at, the patients. So we are not in a formal hospital at home right now, right? We're researching and kind of doing some work around that. So what we really did was, I guess maybe it's informal, right? We built this to really support COVID and are looking at a formal hospital at home right now. And we've been working through that for the last year, even prior to COVID. We have a team working on that.
Yeah, that'll be interesting how that progresses. Also on the question about cost, how about the comparison of an office appointment cost to a home telemedicine cost? Have you kind of looked at the data about those two?
Not yet. Not yet. There's a group looking at it, a team looking at it, absolutely. But then you've got to take your costs and we've got to relate that to what happened to the patient. So 50 patients had a visit that wasn't in the office. And let's just say it was cheaper. But of those 50 patients, 25 ended up in the ER, 20, 40, you know what I mean? So I think we have to weigh that. We just can't say it's cheaper to do a call. What was the result? And honestly, what happened with the patient? So the best outcome for the patient is they stayed home comfortably, right? And were we able to do that?
Right.
Because even if, let's just say the cost was more in the home, but if we kept them out of the hospital, at the end, what does that look like? So we have our analytic geniuses working on that kind of stuff.
Interesting question here on security. This may not be exact expertise, but have you and your team kind of thought about when healthcare workers bring your technology to the home and some of the security considerations around that and how you able to navigate that?
So I think most of you probably have a pretty robust security team that has to do with computers and all that kind of stuff transmitting. So we had to go through all of that before we could even start the process for anything. So even the 24-hour monitor, when we started that, prior to COVID, some of it is getting through that security clearance that the company has everything in place to prevent any ability for the neighbor baby monitor to hear what's going on.
Yeah, that makes sense.
It was okay. We got through it. And it's not a challenge. And we haven't had any issues whatsoever.
We're about to wrap up. This has been a fantastic conversation. To close, if you look at this landscape 12 to 24 months from now and you kind of peer into your crystal ball, can you offer a prediction that you believe, remote monitoring and hospital at home what do you think could be achieved the next 12 to 24 months that isn't quite in place today?
So 12 to 24 months. Okay. So I think, one of the things is really the population, the patients we serve will have a greater understanding of what this provides to them. And COVID did help with that, right? They really, we really showed patients, we can still care for you and you don't have to be in front of us. From a telemonitoring system, me being selfish is the ability for the team that I work with to have the ability to manage more patients, right? To really be involved with more patients and the ability to drive more quality. And we cannot keep, from an efficiency standpoint, calling people every day, which is what sometimes we do today. So the ability to drive better outcomes, the ability to keep more people out of the emergency room. And we should see ER rates go down because now patients start to feel comfortable calling a provider, having that type of visit and that type of intervention, they'll feel more comfortable not going to the ER. So I think overall, it's just going to be society accepting this as a change. And with everything we've done in healthcare, society, has to accept a change. When doctors stopped going to the hospital, that was huge, right? When we started having hospitalists, we never thought we'd move past that. People didn't like having, providers that weren't their providers. So really, I think just the ability to really engage in it and it's going to drive a lot of efficiency, and we're going to learn more. The one thing I don't want to happen is people's homes to become a hospital. And I know we use the term hospital at home, and that's okay for that 7 days, that 5 days or whatever. But the idea of patients having all these monitors in their home all the time, I think is, it goes a little too far, right?
Yeah,
So what's the right device for the patient? That's
yeah,
gonna
that doesn't seem like the worthwhile or the ultimate goal for either side, right?
right, exactly.
There needs to be a balance of when it's right to intervene with this type of
Right. And let patients graduate, let's just not control them. Let them graduate if they can. Some can't, and that's okay.
Yeah. Well, thank you so much for your insights. Joanne Chandra from Geisinger shared some really interesting perspectives and lessons learned about hospital at home and telehealth and remote monitoring. Of course, all of these areas have evolved so much in the last year and a half. Thanks so much for being with us today, Joanne. And we'll definitely catch up soon.
I hope it was helpful. Everybody be safe and have a great week. Take care. Bye-bye.
Certainly helpful, beyond helpful. We will kick it back to our publisher, Matt Rayner, to close today with some final thoughts.
Thanks, Rajiv, and thank you, Joanne. What a great way to close out day one of the Mid-Atlantic Virtual Program. I want to thank you all for joining us here, whether it is live today on June the 14th, or you're watching this content on demand. Thank you for participating in the Mid-Atlantic Virtual Summit. We hope you can join us tomorrow for day 2, which is beginning at 9:30 a.m. Eastern Time. With that said, I wish you all a wonderful rest of the day, and we hope to see you here tomorrow. Thank you.